Clinical Chemistry, Liver Disorders 1, Pathophysiology and Diagnostic Correlation. The liver. So the liver is located in the upper right quadrant of the abdomen, and it has many functions. So sometimes we call this the hub of all metabolism in the body. It plays such vital roles in not only mediating metabolic processes, but also helping to clear out toxins, wastes, and rerouting excess nutrients to where they need to go. There are some functions listed here. This isn't a comprehensive list, but this just gives you a little bit of an idea of what some of the functions of the liver are. So we look at nutrient metabolism, so carbohydrates, lipids, proteins, ketone bodies, storage, so it helps store iron, copper, vitamins A, D, B12, E, and K. The excretion of bile salts, and bile salts, as you may recall, are required for emulsifying fats. So we have the pancreas, which produces lipase or pancreatic lipase, and that breaks the bonds of the fats, but fats want to go back together, and it requires that bile in order to keep those fat molecules from coming back together. Also, the excretion of bilirubin, and bilirubin is produced as a byproduct of hemoglobin digestion. So hemoglobin, when we break that apart to recycle some of the nutrients and reuse the iron, and the reason why hemoglobin's floating freely in the blood is when red blood cells get old, they get filtered out in the spleen, and then when they're filtered out, they kind of rupture, and then that releases the hemoglobin into the bloodstream. That then makes its way to the liver, where hemoglobin is broken down into biliverdin and then bilirubin, and bilirubin is a waste product that needs to be excreted. And we'll learn lots more about that as we go through the liver lectures. Hormone secretion. Somatomedin and angiotensin, protein synthesis, albumin. We'll talk about the major role that albumin plays in regulating the osmolarity of the blood. Complement factors, coagulation factors, and detoxification and drug metabolism. So the hepatocytes are the metabolic units of the liver, and the sinusoidal surface, it faces the incoming blood, the space of Dis, tissue space between the sinusoid and surrounding hepatocytes, contains fat-storing cells, synthesize collagen, and regulate blood flow. And the intercellular surface, it's contiguous with sinusoidal surface. And then there's the canalicular surface, and all of those you can see here in a typical liver cell. A classic or hepatic lobule, the functional unit of the liver. Boundary is the portal tract. There's connective tissue, and it contains a branch of the portal vein and hepatic artery. So arteries bring blood in, portal veins bring blood out, and the bile duct. The cords of the liver cell or hepatocytes are radiating from the central vein. Plasma proteins, so most synthesized and catabolized in the liver. So synthesized is obviously creating them, catabolized is breaking them apart. They circulate between the blood and extravascular spaces. Passive diffusion, active transport, and pinocytosis. Widely varied, so there's acute phase proteins, carrier proteins such as transferrin, fibrinogen, clotting factors that are not in a serum sample. The reason why is because in serum we allow the blood to clot, and then when we centrifuge it down, all of those clotting factors are contained within the red blood cell portion. So serum is a pour-off of that centrifuged blood tube that does not contain the clotting factors. Immunoglobulins, primarily from the B lymphocytes, are also known as plasma cells. Complement components and enzyme inhibitors. Classification of proteins, so there's simple and conjugated proteins. Simple are globular proteins, water-soluble, albumin, globulins. Fibrous proteins are water-insoluble, and they're structural proteins, such as collagen, elastin, and keratin. Conjugated proteins have some type of prosthetic group attached. So there's the apoprotein, which is the protein component, and then there's nucleoproteins, mucoproteins, glycoproteins, lipoproteins, metalloproteins, proteins, and those all contain groups. So, for example, like a glycoprotein would be part protein, part sugar. Lipoprotein, part fat. The acute phase response. It's a nonspecific response to inflammation or tissue damage, and it's related to cytokines. A positive acute phase response increases in response to APR. A negative acute phase response, or acute phase proteins, decrease in response to APR. So if we look at C-reactive protein, C-reactive protein is going to increase, you can see it going up, in response to inflammation. Alpha-1 antitrypsin and complement component 3. So a pretty complete list of the positive APR proteins are alpha-1 globulins, alpha-2 globulins, and beta globulins. And those are listed there. And then the negative acute phase proteins are albumin, prealbumin, and transferrin. Albumin is a small protein. You do not need to know the exact size of this protein, but it is the most abundant protein in serum and other extravascular fluids: CSF, interstitial fluid, urine, and amniotic fluid. 60% of total body albumin is in the extravascular space. It is a negative APR protein, and it's primarily synthesized by hepatic parenchymal cells, and it's catabolized by pinocytosis in all tissues. Synthesis is controlled primarily by colloidal onconic or osmotic pressure, also by protein intake and the acute phase response. So it is a negative acute APR protein, so as APR increases, the amount of albumin would decrease. Again, it is decreased by the inflammatory cytokines. It's that negative APR protein. The primary function is the maintenance of osmotic pressure in vascular and extravascular spaces. Other functions: the binding and transport of a variety of components. It acts as an antioxidant, an amino acid reservoir, plasma buffer, the net negative charge at physiological pH, and it affects capillary permeability. So here you can see a diagram of colloidal osmotic pressure. So when we have a semipermeable membrane, there's a concentrated solution and a dilute solution. And there's certain substances that are allowed to pass that semipermeable membrane. When we do have an excess in albumin, water is going to want to go to where the albumin has been accumulated to dilute it out. If we have a decrease in the level of albumin, water is going to want to leave that area to kind of make it more concentrated compared to the relative environment. And there's a diagram that talks about hyperosmolality and hypoosmolality and what happens to cells in those types of environments. The clinical significance: it's increased only in acute dehydration. So if suddenly someone becomes acutely dehydrated, it's increased. But it is decreased in a variety of conditions: renal failure, excessive excretion due to increased glomerular filtration, tubular damage, hematuria, or a combination. Hematuria is blood in the urine. Urinary loss with physical exercise and fever. Inflammation, the acute phase response, it's going to cause a decrease in albumin, and that's due to hemodilution, loss of extravascular space, increase in consumption by cells, and decreased synthesis. Hepatic disease, it's a result of increased immunoglobulin levels and loss to the extravascular space, inhibition of synthesis by drugs and alcohol. And anemia, rare genetic deficiency where we have less than 0.5 grams per liter, mild to no edema. The major clinical manifestation is abnormal lipid transport. Transthyretin, or TTR, prealbumin. It exists in a 1-to-1 complex with retinol binding protein. It's involved in the transport of the thyroid hormones T4 and triiodothyronine. Increased in the presence of TTR producing tumor, Hodgkin's lymphoma, glucocorticosteroid therapy, NSAIDs, and salicylates. It's decreased with APR, liver disease, and protein malnutrition. If you're not consuming enough protein in the diet, it's really tough for your liver to make enough protein or catabolize enough protein in order to create anything related to albumin. It's used to assess nutritional status. Increased positive nitrogen balance in patients on TPN. A decrease would be a negative nitrogen balance. C-reactive protein. This is one of the first proteins elevated with acute phase response. Exhibits the most dramatic increases in concentration. Its function is calcium dependent, so in the presence of calcium, it binds to polysaccharides of bacteria, fungi, protozoal parasites. It binds phosphorylcholine, phosphatidylcholine, also known as lecithin, and polyanions or nucleic acids. In the absence of calcium, it binds polycations, which are histones. Once complexed, it activates the classical complement pathway. The clinical significance: there's a dramatic increase following myocardial infarction, beginning at 6 to 12 hours after the infarction, and it can reach levels 1,000 times normal. Also with stress, trauma, infection, inflammation, surgery, neoplastic proliferation. So wide variety of reasons why CRP would be elevated, and this is not a good marker of myocardial infarction. So we don't typically use this to diagnose MI, but it can provide supplemental information if it's drawn alongside of some more specific markers for MI. Cord blood it's usually low, and it increases with intrauterine infection. Clinical determinations are useful: screening for organic disease, assessment of inflammatory disease, detection of concurrent infections with systemic lupus erythematosus, leukemia, and after surgery, management of neonatal septicemia and meningitis, and slightly increased CPR for a longer period is associated with increased risk of congestive heart disease. Alpha-1 antitrypsin, serine protease inhibitor, SERPIN. It inactivates trypsin and structurally related to serine proteases. Neutrophil elastase for phagocytosis, elastase in respiration and circulation. Synthesized and catabolized by hepatic parenchymal cells. Two mechanisms of catabolism: AAT protease complexes removed by SERPIN enzyme complex receptors, or decylated AAT removed by asialoglycoprotein receptors. Increased activity, estrogens, genetic, increased activity against clotting enzymes. The clinical significance: a decreased AAT activity is associated with very high risk for bacillar pulmonary emphysema. Link with primary liver cancer. Genetic variants exist. Secondary decreases would be neonatal respiratory distress syndrome, severe pancreatitis, protein losing disorder, liver diseases, neonatal cholestasis or hepatitis, cirrhosis, hepatocellular carcinoma. Ceruloplasmin. It's an alpha-2 globulin, contains 95% of total serum copper. It's synthesized in hepatic parenchymal cells. Copper is added by intracellular ATPase. It's necessary for normal protein folding and the role in plasma oxidation reduction reactions. Central in regulating the ionic state of peroxidase. The clinical significance: it's increased APR, weak late-acting acute phase protein, and significantly increased by estrogens. Primary genetic deficiency, similar in appearance to hereditary hemochromatosis and normal tissue copper, but increased tissue iron stores. Secondary deficiency due to a lack of incorporation of copper. Dietary copper insufficiency, inability to release copper from the GI epithelium into circulation, or the inability to insert copper into CP, ceruloplasmin. Blood loss, renal protein losing syndromes. Wilson's disease is an autosomal recessive disorder, hepatolenticular degeneration. Deficiency of copper binding cation transporting ATPase, and it's necessary for the addition of copper to ceruloplasmin. It differs from a dietary copper deficiency in that total body copper is markedly increased. It's deposited in the tissues, and sometimes they appear to have a copper color to their skin. So their skin actually changes color because of all of the copper that's deposited in the tissues. So hepatic parenchymal cells, the brain and periphery of the iris, are also markedly noted with that copper sheen. Symptoms usually appear at 20 to 30 years of age. It's manifested by neuropsychiatric syndrome or chronic hepatitis. Copper is typically excreted in the bile, and excretion is deficient in Wilson's disease. It leads to the accumulation of copper, which eventually is distributed throughout the body. So this is a picture showing it in the iris. Low levels of copper, ceruloplasmin in the serum. So when we do blood work and those are low, it could be indicative of Wilson's disease. Accumulates in the liver, brain, cornea, kidneys, joints. So seeing the copper sheen in those particular areas, also on the skin, could indicate this. Characteristic clinical features, so chronic hepatitis, Kayser-Fleischner rings surrounding the cornea, renal tubular acidosis, arthritis, and neuropsychiatric changes. Fibrinogen is a glycoprotein synthesized in the liver, functions in the formation of the fibrin clot, and it's activated by thrombin. It is a positive acute phase protein, also elevated with pregnancy and the use of birth control pills. This is why they associate birth control with clots. So typically they want women to stop taking birth control pills once they reach a certain age because they're at increased risk of forming clots, and that's due to this fibrinogen. Decreased with extensive coagulation during which fibrin is consumed. It's measured as fibrin split products by immunoassay or as clotted protein by a method to determine total protein. Beta-2 microglobulin. It's a small protein that's found on the surface of all nucleated cells. Small amounts are shed by lymphocytes and tumor cells. High plasma levels occur with renal failure, inflammation, neoplasms. Clinical monitoring is useful to renal tubular function. Transplant recipients, question of heavy metal toxicity. Urine monitoring is not useful because of the sensitivity to pH. Also useful for monitoring B-cell tumors. So here's a table of the functions of heme-containing proteins. So hemoglobin, myoglobin, oxygen transport and storage. Cytochromes, mitochondrial respiration. Catalases and peroxidases, enzymatic degradation of peroxide. Cytochrome, drug metabolism. Microsomal cytochrome B5, desaturation of fatty acids, tryptophan oxygenase, tryptophan catabolism. Myoglobin, skeletal and cardiac muscle, one polypeptide chain, one heme group, only releases oxygen under low oxygen tension, and it does have clinical significance. Hemoglobin, going back here, the clinical significance of myoglobin, sometimes during myocardial infarction, we can see a very short but steady increase, and very short term, meaning that rapid increase, rapid decrease. However, this is not currently used as a marker for cardiac events. So we no longer consider myoglobin when we start to look at markers that can indicate a myocardial infarction. Hemoglobin. So in hemoglobin, it has 4 globin proteins. At the center is 4 heme groups, and at the center of each of those 4 heme groups is an iron molecule. And each one of those iron molecules can bind a molecule of oxygen. So each hemoglobin can contain 4 molecules of oxygen. In one red blood cell, there's about 250,000 hemoglobin molecules. So each red blood cell could essentially transport 1 million molecules of oxygen. However, that's never usually the case. We typically don't see 100% oxygen saturation in the blood. So the hemoglobin or protein component, 2 alpha chains and 2 non-alpha chains. And the non-alpha chains are kind of what determine what type of hemoglobin we're looking at. So embryonic hemoglobin has Gower 1 or 2 zeta 2 epsilon, Gower 2, 2 alpha 2 epsilon, and Portland 1, 2 zeta and 2 gamma chains. Fetal hemoglobin, HbF, has 2 alpha and 2 gamma chains. Adult mammalian hemoglobin, HbA, has 2 alpha 2 beta, and HbA2 has 2 alpha and 2 delta. And that all has to do with the amino acid sequence of what's in the chains. So this is just showing the HLA loci for the different genes, and this portion you do not need to know what chromosome each one of these genes is found on, but if you're interested in seeing how these are arranged on the chromosomes, it's chromosome 11 and 16, and you can see the different loci. Fetal hemoglobin is the predominant hemoglobin in the newborn. It's normally absent in adults, but it is present in pathological conditions. So there's genetic beta thalassemia, hereditary presence of HbF, or sickle cell anemia. And it can be acquired. So during pregnancy, recovered from the bone marrow suppression, leukemia, thyrotoxicosis, hepatoma. So some characteristics of hemoglobin F, or fetal hemoglobin. It resists alkali denaturation, and that's the basis of the Singer test. It's 2 times resistant to acid elution as HbA. It's oxidized to met-Hb 2 times as quickly as HbA. Higher oxygen binding capacity than HbA. Bind 2,3-BPG to a lesser degree than adult hemoglobin. This one is extremely important. So fetal hemoglobin has a higher affinity for oxygen than adult hemoglobin. And if you think about where the baby is inside of the mom, the baby's inside of the uterus, there's a placenta, and that placenta has blood vessels. So maternal blood is going to bring oxygen to that interface of where the blood vessels are meeting the placental tissue, and then the placental tissue is routing blood back to the fetus. So when we have fetal hemoglobin on the inside, that fetal hemoglobin wants to grab and hang on to the oxygen. So mom's adult hemoglobin brings the oxygen in proximity to the baby's fetal hemoglobin. The fetal hemoglobin will grab onto the oxygen, and that kind of forces the adult hemoglobin to let it go. If we had the opposite happening, the fetus would never be able to grab the oxygen away from the mom's hemoglobin. So we have to have a higher oxygen binding capacity in fetal hemoglobin so that it has a higher affinity for grabbing the oxygen away from the adult hemoglobin. Electrophoretically, it's slower than HbA. So the function of hemoglobin, it is the main oxygen transport molecule in the body. Tetrameric structure is responsible for its high binding efficiency and transport of oxygen. Each heme molecule can bind 1 oxygen molecule. Each gram of hemoglobin binds 1.34 mils of oxygen. There is subunit cooperativity, or heme-to-heme interaction. So the binding of oxygen to the first group will cause a conformational change, and that causes an increase in the likelihood of oxygen binding to the second group, and so forth. Once it goes on to the third group, the conformational change that happened in the first group and second group makes it more likely to bind oxygen in the third group, and then it continues in the fourth group. So the first oxygen molecule binds with low infinity, but that infinity increases with conformational changes with each additional oxygen that is bound. The same reverse principles are true in the release of oxygen. So it's difficult to get that first one to release, but once it's released, then all of the other ones kind of follow due to the conformational changes that happen in each one of the subunits. So here you can see the oxygen binding curve. There's oxygen tension and oxygen saturation, and this is your normal curve. Myoglobin has a much higher affinity for oxygen than does hemoglobin. And then you can see how oxygen binding capacity changes. So with this curve here, you can see with increased pH, we would move to this curve, increased oxygen affinity or decreased DPG, decreased oxygen release or decreased temperature. So that's with this one. With this one down here, you can see a decrease in pH, a decrease in oxygen affinity or increase in DPG, or oxygen release and increased temperature would cause a shift in this direction. On your qualifying exam, for the hematology portion, you are going to be questioned on like what a left shift or a right shift means as far as oxygen saturation goes. So be sure to review this and take a look at it. You will also may encounter some questions on the clinical chemistry portion of the test regarding hemoglobin and oxygen saturation curves. So you definitely want to make sure for both portions of those tests that are of the test that you review this. All right, so I'm going to try. It looks like these kind of popped up and went away. So let me try to get back. So if it's a left shift, you have a higher oxygen affinity. Let me try to exit out of here. We'll look at it from this view. So you if you have a high hemoglobin F, you have a higher oxygen affinity. Modified hemoglobin, carbon monoxide has a higher affinity for oxygen. Met HB or HB variants, or 2,3 BPG depleted blood would be on that side. Now, if it's a right shift or you have a decrease in oxygen affinity, there's various types of hypoxia, so with severe anemia, heart and lung disease, or at high altitudes. The Bohr effect. So it's important in the mechanism of oxygen transport and acid-base balance. The affinity for oxygen increases as the pH increases due to the binding of oxygen in the lungs. The affinity for oxygen decreases as the pH decreases because it's happening as the release of oxygen in the tissues. So carbon dioxide is converted to bicarbonate, and bicarbonate is a base. So we see a lot of bicarbonate in the lung tissue, and there's a much higher pH in the lungs. So if the pH is higher, that means it's more alkaline. You have more of a base present. And if a base is present, that indicates bicarbonate is there. So as we're expelling out the carbon dioxide, bicarbonate is present there because carbon dioxide and bicarbonate convert to and from each other in the lung tissue. We are going to, at that environment, we're going to want oxygen to come into the blood because that's at the surface of the lungs. So when we do that, you're going to see a high pH increases the affinity for oxygen. In the tissues are producing acids. So if they're not directly producing lactic acid, there's acid byproducts that are coming off from cellular respiration processes. So anytime that you're going to break down glucose to produce ATP from that, and that's going to happen at the tissue level, you're going to see an increase in acids. So acid is going to decrease the pH. So you're going to have a decreased pH in the tissues. When you get blood to the tissues with oxygen, you want oxygen to be released into the tissues because that's where oxygen is needed to do the process of ATP production or cellular respiration. So increased affinity for oxygen as the pH increases, decreased affinity for oxygen as the pH decreases. You will be asked questions in this class and also for your qualifying exam of how the Bohr effects relates to oxygen affinity. 2,3-biphosphoglycerate, organophosphate intermediate in red blood cell glycolysis. The concentration is equimolar with that of deoxyhemoglobin. It binds to the central cavity of deoxyhemoglobin, stabilizes conformation of deoxyhemoglobin, and reduces the affinity of hemoglobin for oxygen. Critical in the regulation of oxygen transport and acid-base balance. Hemoglobin testing, it's measured by a variety of techniques for variance. We do a lot of electrophoresis, so there's the acid and alkaline versions of the electrophoresis. We can do citric acid or different types of electrophoresis in order to determine hemoglobin. The pH of the electrophoretic medium is going to differentiate how far these proteins are going to migrate through the gel. Immunoassay, so it's using antibodies to detect specific types. Molecular techniques, chromatography, or spectrophotometry. Hemoglobin by the cyan-methemoglobin method. So iron is oxidized, iron 2 is oxidized to iron 3 by ferrocyanide. And then hemoglobin iron 2 plus iron 3 cyanide yields hemoglobin iron 3 and iron 2 cyanide. Convert hemoglobin iron 3 to cyanomethoglobin, and you can see the reaction there, and then it's measured spectrophotometrically. And this just shows the detailed structures here of bilirubin and the breakdown of hemoglobin. Iron transport metabolism. So there's intestinal absorption of iron. So we eat iron in the diet and it's absorbed through the intestinal wall and it enters into the plasma or extracellular fluid. From there it goes to the bone marrow where it participates in erythropoiesis or the formation of new blood cells and heme synthesis. There it can go, the erythropoiesis creates those red blood cells and the red blood cells will eventually leave the bone marrow to become freely circulating erythrocytes. Once the erythrocytes have reached their extent of their life cycle, they're going to go to the spleen and you're going to have them filtered out. So there's red blood cell destruction that happens throughout the bloodstream, but also any weakened or aged red blood cells are going to be filtered out in the spleen. Hemoglobin metabolism can then occur. So once the red blood cells are destroyed, hemoglobin is going to be released into the blood, and then that's going to go through circulation, typically goes to the liver. We can immediately take that iron and incorporate it into new hemoglobin, but we can also store it. So ferritin and hemosiderin store iron for later use. This is a picture of all of the mechanisms that I've been summarizing throughout. So the bone, we have erythropoiesis, and then we can put hemoglobin into the red blood cells. And then you can see we have the red blood cells, ferritin to hemosiderin, and then if we want to transport the iron, we have transferrin that transports it through the blood. Ferritin is predominantly in the liver, but you can also find it in other tissues. And ferritin is another storage point for iron. And then the intestinal cells. So as you eat iron, it's going to be consumed and brought in and absorbed into the body, and you can see where that goes from there. So proteins involved in iron metabolism. Ferritin is the storage form of iron. Apoferritin, the protein shell, surrounds the crystalline core of many iron atoms as ferric oxyhydride, or ferric hydroxyphosphate. It's present in most cells. Readily mobilized iron stores released as iron 2. Hemosiderin is an insoluble complex derived from ferritin that has lost some surface protein and become aggregated. 1 to 2 micrometer diameter particles, and it's visible by light microscopy after staining with Prussian blue. So transferrin, it binds to iron for transport to the tissues. Apotransferrin is not bound to iron. So here you can see how that functions in the diagram. Dietary iron, so heme is absorbed directly. Inorganic iron, most in iron 3 state, absorbed as iron 2. It's kept in solution and chelates with gastric acid and dietary components. Absorbed at the apical surface of the intestinal epithelial cells, stored as ferritin and released as needed. It compensates for daily losses. Iron deficiency, or anemia, results from the depletion of iron stores. It develops in stages. Depletion of iron stores in response to prolonged negative iron balance. Drop in hemoglobin concentration, red blood cells become smaller and paler than normal, and fully developed iron deficiency anemia leads to a decrease in hemoglobin. All red blood cell indices are decreased, so MCV, MCH, MCHC, mean corpuscular volume, like all of those different terms there will be covered extensively in your hematology course. Blood smears show hypochromic microcytic red blood cells, hypochromic, so not a lot of pigment to them, microcytic, they're tiny, with abnormal variation in size and shape. There's no visible iron in the bone marrow, and when you do a hemosiderin by Prussian blue stain, you won't see those iron stores. Iron overload hemosiderosis, iron overload without associated tissue injury. Hemochromatosis, iron overload with associated tissue injury. You have cellular degradation, fibrosis, heredity, and acquired forms, typically due to chronic excessive absorption from a normal diet. Sideroblastic anemia, a group of iron overload disorders of unclear mechanism. Hereditary and acquired forms. Hereditary is due to a deficiency of ALA synthase in red blood cells. Iron accumulates in the mitochondria because of metabolic bottleneck. Laboratory measurement of iron. So serum iron is measured by a variety of techniques. Photometry, atomic absorption spectrometry. Reference levels are method dependent. Through modification, total iron binding capacity and serum transferrin can be determined. The general principle, you decrease pH, release iron from transferrin. Reduce the iron from iron 3 to iron 2. Iron 2 forms a complex with chromogen, and it absorbs at a different absorption depending what substance you're going to be using. Then that's measured spectrophotometrically. So total iron binding capacity is equal to unsaturated iron binding capacity plus serum iron. Unsaturated iron binding capacity adds sufficient iron to saturate transferrin binding sites. Remove the excess iron, and then the assay is repeated. Total iron binding capacity is calculated, and then serum transferrin is 0.007 times total iron binding capacity. The percent saturation is 100 times serum iron, total iron binding capacity. Changes in total iron binding capacity. An increase would happen in iron deficiency, hepatitis, pregnancy, or using oral contraceptives. And it decreases during malignancy, inflammation, nephrotic syndrome, malnutrition, megaloblastic hemolytic anemias, or hemochromatosis. So you can see different conditions and how your serum iron and iron binding capacities would differ. So you can pause the video and take a look at these different levels. Serum ferritin is determined by immunologic methods. Plasma concentrations decrease very early in iron deficiency. It's a sensitive indicator of iron deficiency, uncomplicated by other factors. Increase in a variety of chronic diseases, chronic infections, inflammatory disorders, heart disease, malignancy, especially leukemias, lymphoma, breast cancer, neuroblastoma, viral hepatitis, toxic liver injury, hemosiderosis, or hemochromatosis. And then you can take a look at these different disorders and what happens to serum iron, total iron binding capacity, transferrin, serum ferritin, and FEP. So spectrophotometry, bilirubin, the adult diazo reaction, chromogen diazotized sulfonylurea acid, neonatal direct detection, absorption of 454 nanometers, PGB or ALA, the chromogen Ehrlich's reagent, it's acidified DMAB, hemoglobin, chromogen potassium ferricyanide. Fluorometry is used, so porphyrin screen, protoporphyrin, variegate porphyria, uroporphyrin, free erythrocyte protoporphyrin, or zinc protoporphyrin. Coaximetry can be used to measure hemoglobin oxygen binding capacity. Heme degradation by the cells of the reticuloendothelial cells of the system in the spleen. So as I mentioned, when we degrade hemoglobin, that goes to the spleen, those red blood cells, the breakdown in heme protein results in 250 to 300 milligrams of bilirubin per day. Most of it's from hemoglobin in aged red blood cells, the remaining from destruction of red blood cell precursors in the bone marrow, the turnover of hemoproteins in other tissues. So how bilirubin is formed. So first, the heme is cleaved into biliverdin. So the intermediate substance is biliverdin. Biliverdin is something that you're going to see when you take a clinical microbiology course and you start to look at the different types of hemolysis on the plate. So you may or may not know already that when microorganisms infect the body, some of them have the ability to eat through blood cells. And if they do have the ability to eat through blood cells, you'll see some beta hemolysis on a blood agar plate. Beta hemolysis means that they have complete digestive capabilities, so you could see clear through surrounding the bacterial growth. But in alpha hemolytic bacteria, those that can do partial digestion of the blood, what you'll see is usually a greenish halo around the growth. That greenish halo is an accumulation of biliverdin from the incomplete digestion of heme. So our intermediate product is biliverdin, and then biliverdin is broken down into bilirubin. Bilirubin is excreted through the bile and through the digestive tract. Bilirubin is a yellow to orange pigment. It's the major waste product of heme metabolism. Photoisomers exist, so trans, the normal state, hydrophobic or lipophilic. Cis, upon exposure to light, it's more hydrophilic, and secreted directly into the bile for excretion without further modification. Bilirubin transport, so it's transported to liver bound to albumin. It's released in the liver and enters the hepatocyte. It binds to ligand protein Y on the smooth ER conjugated to glucuronic acid, UDP glucuronal transferase, or mono and diglucuronide conjugates formed. So conjugated bilirubin is then secreted by hepatocytes into the biliary canaliculi. So you will hear throughout this lecture and possibly into the next lecture the difference between conjugated and unconjugated bilirubin. So unconjugated bilirubin is complexed with albumin. Conjugated bilirubin is complexed with glucuronal or glucuronic acid. It's converted to urobilinogens by bacteria in the gut and excreted in the feces. It's important to take a look at this diagram and see where unconjugated bilirubin exists and where conjugation happens. So the conjugation of bilirubin happens within the liver, and then you have conjugated bilirubin that leaves the liver. Unconjugated bilirubin is reduced by anaerobic bacteria. Urobilinogens are 3 colorless tetrapyroles, oxidized to bile pigments, and then you have intravascular bilirubin transport. And you can take a look at this diagram to follow the pathway. Haptoglobin. It's synthesized in the liver. 4 polypeptide chains that are linked by disulfide bonds. irreversibly binds hemoglobin during extracellular hemolysis. Each haptoglobin monomer binds two hemoglobin alpha beta dimers. Complexes removed by hepatic Kupfner cells, proteins degraded, iron and amino acids are reutilized, heme metabolized via the bilirubin pathway. Complexes have peroxidase activity, control local inflammatory processes. Natural bacteriostatic agent. It prevents usage of heme iron by bacteria. The clinical significance, it's weak late-acting acute phase protein. It increases in the presence of corticosteroid hormones, nonsteroidal anti-inflammatory drugs, nephrotic syndrome, biliary obstruction in the absence of severe hepatocellular disease, and depletion is a sensitive indicator of hemolysis. Estrogen decreases the synthesis, and most decreases are associated with hepatocellular diseases are due to altered estrogen metabolism and hemolysis. The different forms of serum bilirubin: alpha bilirubin is unconjugated, beta is monoconjugated, gamma is diconjugated, and delta is irreversibly bound to albumin. It's measured in serum and urine by a variety of techniques: chromatography, electrophoresis, photometric, and then there's the chemical method, which involves the diazo reaction and the modified Jendrassik-Graf method. The diazo reaction, you will be asked numerous questions about this on the qualifying exam. Diazotized sulfonylurea acid, the diazo reagent, reacts with bilirubin to produce two azodipyryls. It's a reddish purple at neutral pH, but blue at low or high pH. Direct bilirubin is conjugated bilirubin plus delta bilirubin. Total bilirubin is the bilirubin detected after the addition of an accelerator. So in the Malloy-Evelyn method, they use methanol as an accelerator. In the Jendrassik-Graf method, they use caffeine as the accelerator. This one is probably more commonly performed and more commonly heard of on qualifying exam test questions. The accelerator allows unconjugated bilirubin to react with the reagent. Unconjugated bilirubin is the same as indirect bilirubin. So unconjugated bilirubin, to calculate it, you would take total bilirubin minus the direct bilirubin. Specimen collection. Avoid hemolysis and lipemia, typically a morning specimen. Icteric samples are not commonly accepted. You need to protect this from light. So by all means, you need to usually wrap something around the tube or use a tube that's been tinted to be protected from light. But if it's exposed to light, it will not work. Refrigerate and it's stable for 3 days at 4 degrees Celsius or 3 months at minus 70. Urine bilirubin is usually not present. Only conjugated bilirubin is excreted in the urine. Dipstick is based on the diazo method, and it detects concentrations greater than 0.5 mg per deciliter. It requires a fresh sample because urine bilirubin is very unstable. Just like serum bilirubin, you need to protect this from light and store at 4 degrees Celsius no longer than 24 hours. Urobilinogen in feces and urine. It's increased in urine, hepatocellular function is decreased, excess in the GI tract exceeds liver's capacity to re-excrete it. Viral hepatitis, cirrhosis, or hemolysis. If it's decreased in the urine, you have impaired biliary excretion. So there's cholestasis, or indicated by clay or chalky colored stools. It's detected by a dipstick using Ehrlich's reagent, DMAB based reaction, and it's performed on urine or aqueous extracts of feces. Disorders of bilirubin metabolism. So jaundice, yellow coloration of the sclera and skin resulting from an increased serum bilirubin level. Icterus, so you're going to see excess bilirubin throughout the skin, but you can also see it in the whites of the eyes, and you can see it in the serum. Mechanisms would be overproduction, impaired uptake by the liver cells, defects in conjugation, reduced excretion into the bile, or obstruction of bile flow. Prehepatic or hemolytic jaundice is usually the result of increased hemolysis. Sometimes autoimmune diseases can cause this. Abnormal hemoglobin can cause this, like if a patient has sickle cell anemia. Those sickle cells are going to cause the shape of the red blood cells to take on a crescent moon type shape, and that crescent moon shape can cause the blood cells to increase the amount that they're damaged, and that damage can release hemoglobin, and that hemoglobin can then be converted to bilirubin. Ineffective erythropoiesis, so thalassemia major or pernicious anemia, may result in gallstones containing bilirubin. Levels are usually less than 50 mg per liter. Unconjugated bilirubin would be present. Intrahepatic jaundice, there's an impaired uptake, conjugation, or secretion of bilirubin. So before it gets to the liver, that would be prehepatic jaundice. If there's a disorder in the liver, that's intrahepatic jaundice. It reflects a generalized liver or hepatocyte dysfunction. Hyperbilirubinemia, usually accompanied by abnormalities in biochemical markers of liver function. There's hereditary, like Gilbert syndrome, a small increase in unconjugated bilirubin. Heterogeneous conditions, some due to decreased uptake, some due to decreased conjugation. And then there's secondary, the interference of uptake by drugs, Tylenol, salicylates, alcohol, or infection, viral hepatitis. Defective conjugation, so going back to this picture, if it's in the liver, that means, or it's intrahepatic jaundice, that means that either the bilirubin, the unconjugated bilirubin, is not taken into the liver, and that's what we talked about here, due to decreased uptake, or the other thing is that once it's in the liver, the conjugation portion is messed up, and that's due to decreased conjugation. So when we talk about defective conjugation, there is a hereditary disease called Crigler-Najjar syndrome. It's a rare autosomal recessive disorder that a patient is born with a complete lack of UDP glucuronol transferase. It manifested by very high unconjugated bilirubin in the serum because the conjugation portion cannot happen. Most die of kernicterus in the first year of life. Kernicterus is encephalopathy related to decreased bilirubin that leads to permanent brain damage. Type 2 is a rare autosomal dominant disorder, partial deficiency of UDP glucuronol transferase, unconjugated bilirubin 5 to 20 micrograms per deciliter. Neurological complications are unusual. Response to treatment with phenobarbital, and they have a normal life expectancy. Reduced excretion. So going back to the picture, intrahepatic jaundice, we either can't get the unconjugated in, we can't perform the process of conjugation, or we can't get the conjugated out. So unconjugated would come in, conjugation happens inside of the liver, and unconjugated bilirubin would leave the liver. So excretion into bile is the rate-limiting step. It's caused by hepatocellular damage. It leads to an increase in conjugated bilirubin. Uptake and conjugation is also affected. Increased in unconjugated bilirubin. Secondary causes: cirrhosis, hepatitis, cholestasis induced by oral contraceptives, synthetic sex steroids. So hereditary causes: Dubin-Johnson syndrome. It's autosomal recessive, usually benign, increased in conjugated bilirubin, minor increases in unconjugated bilirubin. Other liver function tests are normal. It's distinguished by dark pigmentation that accumulates in the hepatocytes. Rotor syndrome is an autosomal recessive, benign condition, increased conjugated bilirubin and urinary coproporphyrins. Lucy-Driscoll syndrome, increased unconjugated bilirubin due to circulating inhibitor of bilirubin conjugation. Hyperbilirubinemia is mild and it only lasts 2 to 3 weeks. Then you have posthepatic jaundice. This is caused by an obstruction of the biliary tree, so gallstones or cancer. Conjugated bilirubin is high. Other biliary metabolites, bile acids, accumulate. Hyperbilirubinemia is proportional to the obstruction. So the greater the obstruction, the higher the levels of bilirubin. And it's going to be conjugated bilirubin in posthepatic jaundice. Characterized by pale-colored stools and dark urine. In a complete obstruction, urobilin is absent from the urine. Physiologic jaundice of the newborn. An increase in unconjugated bilirubin, caused by immaturity of glucuronal transferase. It peaks within 1 to 7 days of birth. Bilirubin levels typically less than 5 mg per deciliter. If greater than 5 mg per deciliter on the first day or 10 to 12 mg per deciliter later, there is the potential of kernicterus. It's treated by phototherapy, converts bilirubin to stable non-toxic isomer, and exchange transfusions are rarely necessary. So talking about my own child that had this, my baby was born by cesarean section, and his cesarean section was scheduled for a week prior to his due date. After being born, his bilirubin was high, so they did a scan, and it goes right through the skin, and it's just a light that they press on the forehead of the baby, and it goes through the skin, and they can measure the amount of bilirubin or get an estimate of the amount of bilirubin that's accumulating in the tissues. So his was high, and there was some concerns. One of the issues was in newborns is they don't poop a lot, so you got to try to get them to eat more and poop more. The more aggressive their appetite is, the more that they're going to be releasing all of these waste products from their digestive tract. So they try to get them to poop and get rid of the bilirubin that way. But sometimes they have really slow digestive tracts, especially if they're born a little bit early. So the next step to that would be exposing the baby to light. And this is why we don't want to expose our blood samples to light if we're trying to get a bilirubin measurement, because light destroys bilirubin. So when we expose the child to the light, it's usually a blanket that we can wrap the baby in. There are also like lights that can be shown on the baby, and you can take lights home from the hospital if the baby has this. But if you do not get the bilirubin under control, and if levels don't normalize and decrease within a certain period of time, there is the potential for life-threatening, prolonged, and permanent brain damage from the accumulation of bilirubin. So that's something that every newborn is screened for. As soon as they come out, they get all their checks done, and that's one of the checks that's done with the baby. Jaundice in the neonate with unconjugated hyperbilirubinemia. Unconjugated hyperbilirubinemia is a serious condition, especially in low birth weight babies. It results in kernicterus, necrotizing syndrome due to bilirubin neurotoxicity, and it's prevented by that phototherapy and exchange transfusion. Hemolytic disease of the newborn results from an Rh incompatibility between mom and baby within the first 2 days of life. They are susceptible to kernicterus. Breast milk hyperbilirubinemia is caused by alpha-glucuronidase in breast milk. It deconjugates the bilirubin in the intestine. So serum bilirubin in the newborn, direct spectrophotometric determination is possible. Serum of newborns does not contain keratin and other pigments that would interfere at 454 nanometers. So we can do this in newborns. We can't do it in adults. Conjugated hyperbilirubinemia of the newborn. Conjugated bilirubin is greater than 30% of the total. Idiopathic neonatal hepatitis, so giant cell hepatitis, which is characterized by cholestatic jaundice. Biliary atresia, or obstruction of the bile ducts, can be caused by viruses, cytomegalovirus, reovirus 3, Epstein-Barr, or rubella. Other causes, alpha-1 antitrypsin deficiency, Down syndrome, or trisomy 17 or 18.